We can get started. Hello, everybody. I'm Nicole Cyberlick from the University of Michigan, and I'm happy to welcome you to our August CMR Journal Club. So the topic for this month is looking at myocardial T2 star mapping. So this is, an interesting parameter that we have to work with because it allows us to understand, especially what's going on with the iron content within the myocardium. But of course, T2 star mapping is really hard because the signal decay is really fast. And so we are going to start our journal club with a technical paper talking about how we can generate high-resolution T2 star maps at 3T, and then move on to a paper that has more clinical focus, looking at how we can use some of these values to assess patients with thalassemia. So with that introduction, I'm going to hand over to our first presenter, Dr. Xingmin, and she's going to be presenting on the paper entitled Non-electrocardiogram-gated free breathing off resonance reduced, high resolution, whole heart myocardial T2 star mapping at 3T within 5 minutes. It's a mouthful because there's a lot going on there. So please go ahead and take it away.
Okay. Thank you, Nicole. Okay, let me share my screen.
Perfect. Right. We can see it.
Okay, thank you. So first of all, thank you for having me here at the CMR Journal Club. Today, let me briefly introduce our recently published work in MRM. The title we already have that. I'm not going to repeat it. So the motivation of this work is to develop a T2 star CMR technique without the need of breath holding or ECG gating. For now, the clinical used conventional T2 star CMR is based on 2D breath held ECG triggered segmented MGRE acquisition. But in many cases, patients with cardiovascular diseases.
I'm sorry to interrupt. Can you zoom in a little bit? I think for most people who do not have very big screens would help. Thank you.
Okay. All right. This okay?
Yeah.
All right.
Wonderful.
All right. So as I said, currently the conventional T2 star in many cases patients with the cardiovascular diseases with myocardial iron overload, such as hemorrhage or thalassemia, often suffer from impaired cardiac functions such as arrhythmias, and also it will limit their ability to hold breath or take a long CMR scan in the scanner. As a result, it will induce pardon me, artifacts on T2 star CMR images, such as respiratory and cardiac motion artifacts, and deteriorate the diagnostic capability of T2 star CMR for intramyocardial iron quantification for downstream therapies. So in this work, to address those issues, we developed a fully ungated rapid T2 star CMR technique based on a low-rank tensor framework, where cardiovascular T2 star images were represented as a 4-dimensional tensor, including spatial location, respiratory motion, cardiac motion, and echo time. We use continuous randomized Gaussian distributed Cartesian K-space acquisition to avoid synchronization between sampling and periodic motions. And a two-step low-rank tensor completion algorithm was used to avoid large computational expenses. The proposed a technique was also the proposed technique was both tested on domestic swines and healthy human volunteers for validation. The ferromoxetol, and also we gave ferromoxetol contrast to a subset of the animals as iron contrast to lower the myocardial T2 star to simulate hemorrhage or thalassemia conditions. Image analysis was performed, including overall image quality score of resonant artifacts extent coefficients of variation of septal wall and LV cavities. So here, let me show some results. In figure 2 here, we're showing a comparison of T2 star weighted and T2 star maps acquired by the conventional 2D and proposed 3D approach at base, made an apex of left ventricle from one of the animal studies. In this study, acquiring a full stack of 2D conventional T2 star CMR images averagely took about 13 minutes, and one set of 3D low rank tensor data took less than 5 minutes. So in this figure, from the raw T2 star weighted images, we can see the proposed group showed better image homogeneity than the conventional group. And on T2 star maps, areas with lower T2 star indicate of resonance artifacts caused by susceptibility differences at the heart-lung interfaces. And figure 2D here is the histogram of T2 star values from the two T2 star maps at apex. On both histograms, the major peaks are the distribution of normal myocardial T2 star values, and the second peak indicates the distribution of the T2 star values within the off-resonance areas. There is a significant reduction of the second peak based on the histograms in group of proposed approach. This phenomenon is mainly due to the different respiratory phase in which the images were reconstructed. For example, in conventional T2 star approach, images were usually taken at inspiration for patient comfort, but in the motion resolved low rank tensor approach, we were able to reconstruct images at expiration and when the volume of air in the lungs is minimized. So here in figure 3, we're showing the image analysis results in animal studies. The numbers showed a significant reduction of resonance artifacts, volume, and improvement in image quality by the proposed approach. Coefficient of variations both T2 star weighted images and T2 star maps and COV of LV cavity are all reduced in groups of by the proposed approach. We showed a case of unsuccessful ECG gating T2 star images when using the conventional 2D T2 star approach in figure 4A here. And normally, a repeat scan would be performed in situations like this, which may potentially extend overall scan time. But this kind of error will not happen when using the proposed low-rank tensor approach. In human studies, we performed image analysis on images by conventional 2D T2 star CMR and proposed low-rank tensor CMR. The low-rank tensor images were reconstructed at both expiration and inspiration to be consistent with the conventional approach. Both the histograms in figure 5D here and the bullseye plots in figure 5E showed aligned results with animal studies that of resonance artifacts were reduced on low-rank tensor T2 star images at expiration comparing to that at inspiration. And in general, the difference in of resonance artifacts came from different respiratory phases as shown in figure 6A here. Comparing to conventional approach, image quality was improved by the proposed approach at same respiratory phase and further improved when images were reconstructed at optimal respiratory position. So the COV of septum and the LV cavity was lower in proposed group, but no differences were found in case of T2 star. So in human studies, even with healthy volunteers, the successful rate of acquisition with acceptable T2 star image quality is about 80%. Mostly, the failed scans were due to unsuccessful breath holding as shown in this figure 7A. which emphasizes the advantage of the free breathing technique the proposed low-rank tensor approach provided. At last, we validated the accuracy of T2 star measurements by the proposed approach. The T2 star were measured within septum on native and ferumoxidil enhanced T2 star maps. The numbers showed great correlation and minimum bias between the proposed 3D low-rank tensor approach and the conventional 2D T2 star approach. So in the end, we concluded that the proposed low-rank tensor T2 star CMR approach can significantly reduce image artifacts from undesirable motion and off-resonance effect, while significantly shortening the acquisition time as well as providing accurate T2 star analysis.
Great, thank you so much for describing this really great work. We can now take questions. So I see we already have a question in the chat, but please feel free to either type your questions in the chat or you can unmute yourself when there's a pause in the discussion to ask your question yourself, whatever you're more comfortable with. So I'm going to read the first question from our chat. This is from Dr. Liu, and it says, for continuous acquisition, the scan becomes steady state imaging. Signal will be affected by T1 relaxation. How is T1 relaxation handled in your technique?
Yeah, so basically we use a very small flip angle. I think that's a very common way to reduce T1 weighting, but it will add some T1 weighting to it, but the T2 star decay will not be affected by the T1 weighting when you do the maps.
So is this something that could be built also into the reconstruction framework that you have? Like to be able to pull out the T1 weighting or reduce the amount of weighting that you have in your images?
No, for this one I only acquired multiple echoes during the consistent continuous acquisition, and we didn't do any T1 fix or any T1 weighting or enhancement during my reconstruction process. Yeah.
Okay. Matthias has a question. Go ahead.
Yeah, so very interesting and so well presented. I have a question because we are also applying T2 star sensitive imaging with different breathing maneuvers, and the difference you saw between the approaches, the breath held and the other. So could it be that the breath held also has a higher T2 star because of that vasodilatory effect of a breath hold? Because if you hold your breath, especially when in expiration, then carbon dioxide will increase. It's a vasodilator for the heart, so T2 star should increase. So I wonder whether that could be the mechanism that's behind the difference between the two breath held versus continuous breathing.
Yes, I agree. There might be a marginal. I don't have a number between the T2 star values when inhale and exhale. But for the off resonance, I think the difference is is over. You see the areas of the off resonance. I think there might be slightly difference between T2 stars, but the areas of of resonance is the T2 star changes so dramatically. I think it will not be. Mostly, it will be still the off resonance, the susceptibility changes, not the T2 star change.
Because in healthy people we see a difference of up to 20% in the signal intensity with the breath hold. So it's also not insignificant. I just wanted to say that.
Sorry. Yeah, sorry. Then that I may be I made a mistake. But from the results here, I don't see. So could you share some more information about the 20%? It's a normal myocardial T2 star.
In healthy people, because of a long breath hold and it induces carbon dioxide increase, you have a vasodilation, and that in the brain and the heart leads to a signal. I can send you something. I don't want to spend too much time now. We have the next presenter already waiting, but I'm happy to send you a few papers that we published on that.
Okay.
Great work.
Um,
Congratulations.
okay.
All right, perfect. So in the interest of time, let's thank Dr. Guan again, and we're going to move on to our next presenter. So this presenter is Dr. Antonella Maloney, and she'll be presenting the paper entitled Multiparametric Cardiac Magnetic Resonance in Patients with Thalassemia Intermedia, New Insights from the E MIOT Network.
Oh,
Go
can
ahead.
you see my screen?
Yep,
Okay.
yep, perfect.
Okay. So, thank you for the opportunity to present this work from the Italian E MIOT network. In thalassemia intermedia, complications are due to ineffective erythropoiesis, chronic anemia, and iron overload. As you know, iron overload is toxic and can cause organ dysfunction, but the T2-star MRI allows its non-invasive and reproducible quantification. However, the studies focused on cardiac T2-star measurements in thalassemia intermedia patients are very limited. In thalassemia intermedia patients, we can expect an enlargement of the cardiac chambers due to the chronic anemia, and the CMR is also the gold standard for the quantification of biventricular function parameters. However, the literature focused on biventricular function in thalassemia intermedia patients is really limited. Final CMR is also the gold standard for the non-invasive detection of replacement myocardial fibrosis, but there is no data about the prevalence and the association of replacement myocardial fibrosis in thalassemia intermedia. So the aim of this study were to investigate myocardial iron overload by ventricular function parameters, atrial dimensions, replacement myocardial fibrosis in thalassemia intermedia patients, highlighting also the difference between regularly transfused and non-transfused patients to assess the clinical determinants of global T2-star values and to explore for the first time in thalassemia patients the association between multiparametric CMR findings and cardiac complications, including heart failure and arrhythmias. We selected 254 thalassemia intermedia patients, and 60% of them were regularly transfused. MRI exams were performed on clinical 1.5 Tesla scanners, and we used the T2-star sequence for hepatic and cardiac iron overload assessment. For the heart, we used a multi-slice approach. We assessed the T2-star value in all 16 myocardial segments, and the global T2-star was obtained as the mean. And liver T2-star values were converted into liver iron concentration using the calibration curve. SSP images were used to quantify biventricular function parameters and atrial dimensions in a standard way, and we used LG sequences to detect replacement myocardial fibrosis. We did not use the conservative 20 millisecond cutoff for the detection of iron overload, but we used a more sensitive and specific cutoff of 32 milliseconds. This table shows the comparison between regularly transfused and non-transfused TI patients. No difference was found in terms of age and sex, but regularly transfused patients were more frequently splenectomized and chelated and showed significantly lower hepatic iron levels, but significantly higher cardiac iron levels, significantly lower biventricular and diastolic volume, left ventricular mass index, and left ventricular cardiac index. No difference was found in the replacement myocardial fibrosis or biventricular ejection fractions. In non-transfused TI patients, T2-star values were not associated with age, gender, or other clinical parameters. In regularly transfused TI patients, global attitude star values were positively correlated with aging, duration of the regular transfusion, and negatively correlated with hepatic iron levels and serum ferritin levels. In regularly transfused TI patients, we performed a stepwise regression analysis, and we found out that age and serum ferritin levels were the strongest predictors of global attitude star values. In particular, serum ferritin level higher than 786 nanograms per millimeter predicted a pathologic global attitude star with good sensitivity and specificity. Cardiac iron levels were not associated with attitude star values. Okay, the table shows, okay, I arrived to the table. Okay. This table shows the comparison between patients without and with replacement myocardial fibrosis. There was no difference in terms of age, gender, cardiac iron levels, and ventricular function parameters, but patients with late gadolinium enhancement showed a significantly higher right atrial area index. Of note, not all our patients received the contrast medium administration, but only 103, and the frequency of positive LG was 26%. Globally, 25 patients had a positive history of cardiac complications, and no difference between patients without and with cardiac complication was found in cardiac or hepatic iron levels or biventricular function parameters. But patients with replacement with cardiac complications were significantly older, showed a significantly increased left atrial area index and a significantly higher frequency of replacement myocardial fibrosis. In the multivariable regression analysis, increased age and replacement myocardial fibrosis emerged as the significant risk factors for the cardiac complications. Okay, I go to the discussion. Okay, in our population, regular transfusions increase the risk of cardiac iron overload. However, we can say that the degree of cardiac iron load was generally low. Conversely, regularly transfused patients have significantly lower hepatic iron levels compared to non-transfused patients, which can be explained by the different intensity of chelation. As expected, both regularly transfused and non-transfused patients have enlarged ventricles compared to normal health volunteers, but we found out that regular transfusions were effective in reducing the negative hemodynamic effects of anemia. We detect a serum ferritin cutoff, which can help to detect those patients with an increased risk of cardiac iron levels. This cutoff can be particularly useful in those situations where cardiac MRI is not, of course, available. Cardiac iron was not associated with biventricular function parameters, which can be explained by the mild degree of cardiac iron overload. This is the first study to document replacement myocardial fibrosis in thalassemia intermedia patients, non-invasively in vivo by CMR. But we did not find an association between myocardial fibrosis and cardiac iron levels or biventricular function parameters, likely because conversely to iron or dysfunction, myocardial fibrosis is not reversible. Moreover, we have a small number of patients with positive LG due to the low number of patients who received the contrast medium administration. However, importantly, myocardial fibrosis emerged as the CMR marker more strongly associated with a positive history of cardiac complications. The strong limitation of our study is its cross-sectional study, and taken together, our data suggests that multiparametric CMR, including assessment of iron, fibrosis, and cardiac size, can be useful for the management of thalassemia intermedia patients. Thank you for your attention.
Great, thank you for this very information-rich paper on this interesting patient population. Are there any questions? Oh, Matthias is clapping. I thought he had a question, but let's see. Is there anyone in the chat? Not yet. I'm going to ask a question while I'm waiting for everyone to formulate their questions. So I believe, and I could be mistaken, so you said you were collecting data on scanners from multiple vendors. Is that right?
Yes.
So got
Yes.
it. And so how did you harmonize the protocols across the vendors? Or, did you see, differences in the quantitative measurements that you were making across those vendors, or were they all very similar? How did you look at the data from those different places?
Okay, the MIOT network is a multi-center study, and all MRI centers enter in the network after a validation procedure. So all centers have the same T2-star sequence. We talk with all vendors to uniform the sequence parameters, in particular in terms of echo times, echo spacing, flip angles. So the sequence is similar for all the centers. And all centers use the same software, which is called E MIOT, for the T2-star assessment. So before, we have a standardized technique for acquisition and image analysis. Moreover, all centers do a validation procedure. 5 patients travel between Pisa, which is the reference center, and the peripheral center, and we measure the T2-star in all scanners. And it's important that the difference is between 5%. So if the center is okay, after it can enter in the MIOT network. So this is a accurate validation procedure to eliminate all the differences possible between scanners.
Yeah, that validation is amazing. That is extremely cool, actually, that you're able to do that.
It takes a long time also because the patients have to travel. We are trying to do the same thing for the T1 and T2 mapping, but it's more complicated.
Of course, yes. Yep. Go ahead, Matthias.
Yeah, I'm interested in your observation of the fibrosis in the myocardium, and you briefly speculated on that, but there are several reasons, potential reasons. So it could be the anemia that is associated with that, the iron overload itself, with the oxidative stress, or even inflammation. So, I mean, you see a lot of patients. What do you think is the most likely?
Of course, we think the most likely explanations are iron overload. Also, the anemia, which of course can cause a stress on the cardiac chambers. Many of the patients have started the transfusions late in life, so they have been anemic for a really long time. We can also consider that many patients had a past history of infection, hepatitis C virus infection, which of course can be another causative factors. We need to do more studies to really understand the causative factors for fibrosis, but we are pushing to its assessment in all patients because it really has a strong diagnostic and prognostic value.
Thank you.
Welcome.
All right, if there are no further questions, then let's thank Dr. Guan and Dr. Maloney one more time for their excellent presentations. Perfect. And then I want to first put in a plug for the upcoming August JCMR Journal Club, which is next week, Wednesday, at 11 a.m. And the topic is going to be mitral annular disjunction, where is the boundary between normality and disease? And I'm going to hand it over briefly to Matthias to talk about the next CMR Journal Club.
Thank you. So interesting, the Journal Club today. Next September, on September 4th, we will have the next CMR Journal Club. And because of the vacation, I do not have the final okay of both authors, but we will talk about first-pass perfusion, about novel protocols and analysis methods that use machine learning. So if you're interested in perfusion, that will be a very interesting CMR Journal Club. So thank you, everybody, from my end too. Back to you, Nicole.
All right, then we can wrap up for this week. Thank you again, everyone, for joining us, and we'll see you back in a month. Bye, guys.
Bye.